I'm here to teach you guys about high performance CPR for first responders. So I have a little bit of experience in the fire service and EMS. I have been here for a little over 2.5 years at Chena Goldstream Fire and Rescue, and I think high performance CPR is really important, and it's something that we should all strive to be a little better at. So what do you guys think we should do better here at Chena Goldstream with CPR? Kelly?
Practice it more often. Practice makes perfect.
So luckily we're going to do that today. So even though CPR, with the implementation of high performance CPR from King County, the nation has improved overall, but there's always room for improvement, and I think first responders take CPR for granted and they think they know it really well because they're certified, but their skills tend to lack when they don't practice. So like Kelly said, that's what we're going to do today. So first, I'm going to give a quick lecture. It shouldn't be more than 8 or 10 minutes long about CPR, and then we're going to do a scenario where you guys are going to go through a code. And then afterwards, we're going to go through what we thought went well, what we thought went bad, or needs improvement, and then we're going to discuss any confusion or questions that anyone might have. So for training purposes, I need to know what all of your levels of training are. Kyle.
I'm a state licensed paramedic.
Kelly.
EMT2.
Joe.
EMT3.
Pierce.
EMT1.
Cheyenne.
EMT3.
Okay. And specifically, what do you guys want to learn from this training? I know we do CPR a lot, but is there anything specific that you guys want to know?
Drug dosages.
Well, okay. Anything else?
How fast are you supposed to do it?
How fast are you supposed to do it? That will be shown in the PowerPoint.
Oh, good.
So when you, like he was saying, practice is really important. So that's why the scenario is going to be fun, and it'll instill the things that we need to know / already know. So for my performance, my PowerPoint here, as I said, I'm doing high performance CPR for first responders by me. Oh, come on. Fix that. Don't worry, I can cut that out too. Okay. So, importance of CPR. According to AHA, there are 350,000 out-of-hospital cardiac arrests a year in the United States. Almost 90% of them they die, unfortunately. Things we can do to fix that is we can teach CPR to bystanders. So the more people that are CPR instructor certified, the more people we can teach in the area so that they can start CPR, because our transport times are so long that really they're the first line of defense, not us. Another way to help mitigate that, that's a little bit above my pay grade, but if dispatch were to coach them through those CPR compressions immediately. But immediate CPR drastically increases survival, obviously, because the longer their heart is stopped and their blood isn't circulating, the less chance they're going to have of surviving. So, like I said earlier, first responders take CPR for granted. I've been to symposiums where people are certified and they're lead medics even, and they're doing compressions in completely wrong places, the wrong rate, wrong depth, everything. And that's not that, they're bad medics or anything like that. It just means that they didn't pay enough attention to it. So high performance CPR, it originated in King County, and it emphasizes minimizing compression breaks. You want to make sure that compression's above everything else, above airway. It used to be that airway and checking for a pulse were more important. It used to take up to 30 seconds to get compression started, and that is highly discouraged now. And King County has done so well that AHA has adopted the method due to its success. So statistics, high performance CPR was implemented in King County area after 2002. In 2002, they had a 27% save rate, which isn't bad, but it could be better. And after they implemented high performance CPR, it went all the way up to 62%. And from from a King County person that I talked to, they said that slightly after they implemented it, it went down because people like to fight change. But once they got used to it and they practiced it, then it went back up and they went all the way up to 62%, and it's been spreading throughout the nation ever since. So our department, we are pretty rural. We have long travel times, and unfortunately that leads to minimal saves. We have had saves. Joe was just on one. Yay! And clearly it's because of our travel distances and the lack of bystander CPR. Bystanders may do CPR, but it's not always the best quality. However, regardless of travel times or anything like that, we always have room for improvement. So, from go, we get dispatched to a call. First thing you want to do when you've arrived and you know the scene is safe is you want to assess the victim. Do they have a bystander doing CPR or not? That's something you should know. If you are not with an ambulance and you're just out there by yourself, you need to activate the emergency response system, also known as calling 911. Or have somebody do that for you while you are checking the pulse. And then if there's no pulse and no breathing, you want to start compressions. And since you're all responders, you know how to do compressions already, but we're going to review that in a little while. And the next most important thing after compressions is integrating a prompt and proper use of defibrillation. So that's either the ZOL or the AED. So I know that we all know the difference between witnessed and non-witnessed. That refers to emergency responders. However, a lot of people, there's some confusion about when you should shock, whether it's witnessed or non-witnessed. So for witnessed, you want to deliver the shock after 30 seconds. You want to make sure you saw it happen, and so you want to use the defibrillation as soon as possible. But only if it's a shockable rhythm, which the lead medic will be reading on the ZOL. Non-witness is when it could have been witnessed by a bystander, but it wasn't witnessed by EMS. So if it's non-witnessed, you want to complete a full cycle of CPR before you even start shocking. So compressions. I know that we do this a lot and it's overdone, but it's always good to review. You want to go at a rate of 100 and 120 beats a minute, or, the song Staying Alive, like everyone's always heard. Hand placement, you want to go on the lower half of the breastbone, and for people, you want to go at the nipple line, right in the middle. For death, you want to go at least 2 inches. I believe that the specific number is 2.4. And then chest recoil, you want to make sure that after you've done your compressions, that the chest goes all the way back up so that it allows the heart to get its full amount of blood going through the heart. And minimal interruptions, that's really important. It's easy to get distracted with all the advanced interventions. Compressions are the most important. And you want the interruptions to be less than 10 seconds. Those interruptions should only be things like analyzing the heart rhythm where you absolutely can't be compressing anymore. So for proper compressions, you see that their arms are locked out, they're using their waist as a fulcrum, and they're going all the way down and letting the chest go all the way back up. They're not going too fast. I think that's a habit that most first responders have. They've heard push hard, push fast for so long. They push as fast as they can, and it's not the best rate, and it's not the best rhythm, and it doesn't get full chest recoil or full depth. So everyone hates the metronomes that are in the ZOLs, but they're really important. If you don't have them, then you can use it on your phone, or just slow down. You just gotta think about slowing down a little bit in your head. So for the ZOL and the AED, this is one of the roles that happens during a code. You want them to apply the defibrillation pads, and also the 4 leads if you're using a ZOL. That's not on the AEDs, but the 4 lead helps the lead medic analyze the rhythm. So you also, when you're analyzing, you want to stop compression so that you can read it, otherwise you're not going to get a good reading. And then if it's a shockable rhythm, you push charge and you need to continue compressions while the charging is happening. And then when it's ready to shock, you call clear and you confirm that everyone's hands are off. You don't need to, go back 3 steps, but your hands need to be completely off of the chest or anywhere on the body. And then once you shock, right after shocking, you need to begin compressions again. It should be immediate. It's really important to do that. So for the airway, you want to start with just a BLS, basic life support airway. You start with an oral or a nasal adjunct, and then the BVM, and you can add supplemental oxygen. Once you get medical direction and the code is already established and everyone's got the BLS interventions down, then you can do an advanced airway. That can be a king tube or a combi tube, which we don't carry, but it's possible to use, or an endotracheal intubation. Again, if that's taking too long, just go for the easiest route. We want to keep compressions going and stick to the BLS interventions. So IV medications, again, I know it's a bit redundant to say that, but it's really important and people forget. BLS is important. You want to get vascular access once everything is established so that you can get medicine on board as soon as possible. You want to, if you can't get an IV with a large bore catheter, then you can go to an IO, which is intraosseous access, as you all already know. And then you don't push drugs without the team lead telling you to, and you confirm it using really good communication and closed loop communication. Some of the medications we use up at a 3 level are epinephrine 1 to 1,000, lidocaine, atropine, and morphine. Morphine is just for chest pain. It has to be a conscious patient, but I thought I'd throw it in there. So on the left there is the IV, and on the right here is the IO. So the team leader, it's you, Kyle. You're the overseer of the scenario. You keep time so that you're keeping the 2 minutes in your head, and you have quality control. So you're telling people if their depth is too much, how good the compressions are, that sort of thing. And you're keeping record, if you don't have an extra person there, of when the medications were pushed and things like that. You may also be assigned to the Zola ED if we don't have enough people. I know that this is hit a lot, but BLS over ALS. So I mentioned closed loop communication a little bit earlier, but you want to, so say I tell Cheyenne that I want her to push medication. She needs to repeat back to me what medication and how much. That way there's no confusion about what's being done. And that way if she says the wrong thing because she was confused, I can say no and clarify the situation. You want to verbalize everything to the reporter because sometimes they can't hear. You also, it doesn't hurt for whoever's compressing to count their compressions so that if they haven't established an advanced airway, then they can let them know when the breathing needs to happen. And then the team leader needs to clearly assign roles, preferably before we're on scene. That way there's no chaos about who's doing what. I got my sources from King County. That is who started high performance CPR, and also the American Heart Association. That's where I got some of my statistics. All right, any questions on any of that? No. So we're gonna take a quick break while we set up the scenario, and while Kyle, you're gonna be the team lead, and you're gonna assign jobs based on their certifications, okay? So we're gonna take a quick break, and I'll set it up. I'm gonna turn the light. I'm sorry, I talk so fast. Alright, so Kyle, go ahead and assign your roles. You're in the medic right now.
Joe, you're gonna be on the airway. Kelly, I want you on IV access and med administration. Cheyenne, I have you on the monitor. Ike, you'll be doing compressions.
Alright, so you guys are dispatched to a 60-year-old male that had been complaining of chest pain and collapsed on the floor. The patient's wife called 911, who directed her to begin compressions. The scene is safe, and participants arrive on scene to find the wife beginning to tire from the 5 to 10 minutes of compression. And go.
Ike, check for a pulse. If there's no pulse, begin CPR. Get on the airway. Let's get the monitor put on. You're gonna
Venus access, please. Ike, count out your beats as you go on. Alright, this is a witness arrest with CPR in progress.
Yep.
So as soon as we can, let's get the monitor on and analyzing. You ready to give a shock?
Left proximal tibial IO.
IO established.
Monitor's on.
When you analyze, I'll let you know what your rhythm is.
Okay, clear so we can analyze.
VFib.
Seeing VFib, continue. Charging to 120.
Get epi.
Okay,
1 to 10,000
everybody clear?
up.
Epi 1 to 10.
Shock delivered.
Yep. Shock lever 2121. Go ahead and give 1 milligram of epi when you can.
1 milligram epi.
When you feel like you want an advanced airway.
Alright. Joe, you're ready to swap out on the 30 on this one? Swap out with compressions.
One milligram epi.
Alright, epi on board. 2122. Alright, we're 1 minute out. Ike, how's the airway? Do we have good compliance? We do. Joe, make sure to push hard and fast. Rate of 100. Release 2 inches.
Let me know when you analyze.
30 seconds out. Alright, go ahead and analyze on this one.
Okay, everybody clear for an analyze?
Ready to swap?
Pulseless VTAC.
Okay. Continue to do CPR. I'm going to charge to 150. Clear?
Clear.
Shock delivered.
Kelly, your lidocaine drawn up.
Light came up.
You when you're ready.
How much you want?
You do 300 milligrams.
300 milligrams. Milligrams lidocaine on board.
Perfect.
And let me know when your next 2 minutes are up.
How you doing, Ike?
Don't forget advanced airway.
Joe, do you want to go for advanced airway?
I'll take over for you when you're up.
30. I can swap out with you if you're getting tired.
Maybe you check and see if we're getting good compliance with compressions. See if you can feel a pulse.
What's my time on my next analyze?
30 seconds out. Joe, if we're not gonna get that airway in before then, hold off on it. Alright, after this round, we're gonna be analyzing. Ike, be ready to swap out.
normal sinus rhythm.
Yep,
Normal sinus, check for a pulse.
you have a pulse, weekend ready at 42.
Alright, we have a pulse, stop compressions. Keep begging, get a good airway. Kelly, I want you to give me a blood glucose setup. Shayna, go ahead and grab a 12 lead for me. And let's get this patient ready, get him into back to medic, we'll transport into FMH.
Alright, good job, guys. Alright, we'll clean this up in a little bit. We're just gonna go over the scenario. So go ahead and take a seat. Alright, guys, so a couple things. Really good job. I thought there was really good communication. What do you guys have to think about it? What do you guys think? How did it go?
There at the end, there was a little bit of confusion when I had said after this last cycle of compressions, Kelly had started just doing continuous compressions, so it wasn't counting up to 30.
Okay.
That one bit us a little bit, but we recovered from it fine. It didn't delay time on the chest.
Okay, another thing, when the person who's doing the airway is getting ready to switch, you can just ditch that 2 breaths rather than taking the 2 breaths and then switching to compressions. It's more important to get the continuous compressions than to take those extra 2 breaths. There was something else, do you remember it? That was, I don't remember. But you also said left tibial, it's definitely the right leg. Not that that really matters, but just a thought. What do you guys think went well? You said communication. So it was really good to get the practice in. If you have trouble with an airway or something, just make sure you keep the BLS intact. It gets kind of confusing in a real life situation. This is just a training scenario and we got a little bit confused. So it's really important to practice this kind of thing. The other thing is the constant communication was good. It's nice that we have the standing orders protocol because we have consistent protocol. We don't ever have to question what the right dosage is to use. Oh, that was the other thing. When you start a new rhythm, you start again at the top of the cycle. So you went straight to lidocaine when there was a new rhythm. You're supposed to start with epi. Just a
I missed that one.
That's okay. I just was trying to remember it earlier. Sorry. And then the other thing was, it's really important. Obviously, we practice this at station, but it's really important to do your own training and your own study because the more invested you are in the information, the better off the patients will be in the long run. And we want to serve our residents with the best capabilities that we can. Any questions? We're about done. So, any questions? No? All right. Thanks for dealing with me, guys. I know it's been long, but I really appreciate it. So, have a good night, everyone. Yeah.
Don't we look fantastic?
Guys, this is supposed to be 25 minutes long. How
Go.
are we supposed to get through this? What? All right. God damn it.
Cut.
I can cut it out. I